Hi guys, Dr. Sujat Pathan, and we'll continue with the Frcem Intermediate SEQ High Yields topic from where we stopped yesterday. We discussed the last thing was the renal replacement therapy indications, and as we said, it's AEIOU. You guys should know these things. They can ask you a 1.5 mark or 2 mark question, and you need to have to write 4 points. Okay. Let's move on to musculoskeletal, and this will be more of pictures and pictures. Okay, so if you look closely at this X-ray around over here, how would you describe the abnormality on this X-ray?
Base of first metacarpal fracture.
What is first and second? What is
base of thumb fracture?
So it is a cortical disruption or a fracture in the proximal part of the left thumb metacarpal. That's the complete answer. Proximal left thumb metacarpal. Okay. What is the eponym for this fracture?
Bennett's fracture.
Good. This is Bennett's fracture, and when it becomes comminuted and involves the articular surface, it becomes Rolando fracture. Okay. Bennett's, Rolando. It's over here. Follow an outstretched hand. Bennett's, Rolando. Good. Why do you think these two fractures are unstable? Apart from the fact that they are involving the articular surface, why do you think these fractures are unstable?
Near the snuff box.
By unstable, I mean to say you can't plaster it and send home. You will need to involve the orthopedician for open reduction, internal fixation, and wiring. Why? Okay, let me rephrase the question. What are the boundaries of anatomical snuff box?
Around the bones.
So what?
EPL and the...
So what is present radially? On the radial aspect.
EPL.
So that is
Excellent.
extensor or abductor?
Laterally is APL.
What is lateral and what is medial?
Medial is
I have always told you, name them.
Yeah.
This side is volar,
Yeah.
this is dorsal, this is radial, this is ulnar. Nothing is lateral, nothing is medial.
Ulnar.
On the ulnar side, what is there?
EPB is there.
Okay. It is on the radial side, it is APL. On the ulnar side, it's EPL. So the abductor pollicis longus tendon gets inserted over here, and that keeps on pulling the fracture segment out. So it's an unstable fracture. Okay. Now, what is this? Describe the abnormality on the X-ray.
Cortical.
So this looks like a thumb, and cortical disruption or a fracture seen at the proximal metacarpal of the thumb. I don't know which side it is. Likely it should be the right side. They haven't labeled it. Again, this. What is the other name for this? What is the other name for this one? Playing what kind of sports will cause you this injury?
Ball catching sports.
Rugby.
No.
Football.
when the ski gets stuck in the ice, thumb moves back, and skiing injury or gamekeeper's thumb, we call it. So
Gamekeeper's
when they do that, again it is unstable because of the attachment of ulnar collateral ligament. They didn't say medial collateral or lateral collateral, they said it's ulnar collateral ligament. If it's gone, it's unstable, you need to get a hand surgeon involved. However, if you can keep it splinted this way, you can get them seen by the orthopedic surgeon or the hand surgeon the next day also. Now we come to finger injury. This is likely a 14-year-old guy who's left-handed. He got angry and upset over someone and he punched the wall. Now this guy has a cortical disruption or fracture at the distal end of the little finger metacarpal on the left side, also known as boxer's fracture. So when they punch, they break it. The thing which is important is which patient needs to be surgically treated immediately versus which patient needs to be sent home and follow up with fracture clinic.
The dislocated one needs to be treated immediately.
Okay, this patient is there in your emergency department. You have splinted his hand and sent for an X-ray. He comes back from the X-ray, you look at this X-ray. Okay? You have given paracetamol plus codeine for pain management. The bone looks like this on the lateral view. How would you deal with this fracture? What will be your next step after taking consent from the patient? Or you feel you're going to reduce it and send to fracture clinic because there is absence of that sign which we'll come to later on. What will you do next? You've gone and told the patient, I need to reduce it. You've taken consent, he's okay with it. And you told him that we'll put a plaster. So what will you do next?
Analgesia first.
No, that's all given.
What will you do next? You're given paracetamol and codeine.
As I said, there should be a sign which we need to test if that's negative.
That's tested, that's negative.
Then put him on a plaster and send him home, review
Yeah,
in a
you
week's
want to
time.
put a plaster, but before that you'll have to reduce it, right?
No, yeah.
So how will you reduce it?
Traction.
That's an easy answer, traction, counter traction. That I agree. But before doing that, what will you do?
We should remove the previous splint.
Yeah,
Uh,
that is just a sling, arm sling.
It's a dislocation.
Had this been a distal radius, then what you would have done?
Distal radius, then it's Coley's.
Yeah, so what you will do?
Hematoma block.
Don't you want to give hematoma block? And do traction, counter traction? Yeah. So hematoma block, traction, counter traction, plaster slab application, which will be ulnar cutter slab, going to home with plaster care advice, pain management, and fracture clinic. You do it every day, but when it comes to exam, you think that is something different. What I have said was, close your eyes and think you're in the department and answer them. Same way you have tried. So, we'll go to that part. What do you test in a boxer's fracture? You ask them to make a fist. About 10 degree of angulation or rotation is acceptable. 20 degrees acceptable in this one. 30 degrees acceptable in this one, 40 degrees acceptable in this one. So when they make a fist, if it is going like this, it's fine. You'll reduce it, it will come back. But if it is going like this,
Angulation.
there's angulation. That's not acceptable. You try to reduce it. If it's not reducing, then it goes to surgery. What is this?
That's just a smart one. Thumb.
That's a little finger.
No, there is thumb also.
It may be index finger, middle finger, little finger or something. This is the thumb over here. Thumb looks normal to me. What is this?
Sesamoid bone.
No, that is
Okay.
the base of the distal phalanx of the little finger is fractured.
You don't know what finger it is.
Yeah, I don't
Yeah.
know.
There's a avulsion fracture
Avulsion fracture.
at the base of or at the proximal part of distal phalanx of finger. What is it called? Okay. On this side, what tendons are there? Frcem primary tendons. Those who have passed the exam, shame on you if you don't tell it. On this side,
Which ends at the base.
on this side, flexor digitorum superficial is flexor digitorum profundus.
Yeah.
Yeah.
FDP.
On this side, extensor digitorum tendon are there.
Mm-hmm.
When there is an avulsion of the extension digitorum tendon from the distal phalanx, you get mallet
Mallet
finger.
finger.
Mallet finger. So that's your mallet finger. Extensor digitorum tendon is avulsed, and when it gets avulsed, it may take the chip and get the bone out. You put them in a mallet splint, which looks like this. You tell them, keep it on until the orthopedician says. You're going to follow up with the orthopedic surgeon or the hand surgeon. When you're going to clean your hand, keep your hand on the table flat. You remove the splint, clean your hand. Then put the splint back and then lift. They can't do it like this and clean their hand. Otherwise, whatever repair has happened, it will go away. So, that's your mallet finger, mallet splint, extensor digitorum tendon. Okay? What is that?
It's a dislocation.
No. So, in the previous one, what you saw was,
Oh, it's shown.
in the previous one, you saw this was flexed, this was straight. In this one, this is flexed, this is extended, hyperextended.
Weakness.
This is Buttonier's deformity due to central slip. Okay? Central slip is gone. So the central slip is avulsed. That's Buttonier's deformity. Again, you can put them in a mallet splint and ask them to follow up with the fracture clip. Let's go to forearm. So we're done with the finger. We did Bennett's, Rolando, gamekeeper, boxer, mallet, and button. Okay. Now we'll go to wrist. Wrist, we'll start with scaphoid. The scaphoid looks normal in this, but I'll tell you scaphoid fracture. Scaphoid fracture and toddler's fracture. Think same. This was fallen outstretched hand. That's a rotational stress on spiral fracture tibia in toddlers. Okay. X-ray done, normal. Put in a scaphoid slab or back slab. You put in a long leg cast. 10 days later, X-ray done, abnormal. Okay. So they follow up with the fracture clinic. What is this?
Describe it.
So if you describe the abnormality, there is a cortical disruption with dorsal angulation of distal radius on the left side, right? Colles fracture. If it is This is dorsal angulation. If it is medial angulation, it is
Medial angulation.
the volar angulation is there. Then Smiths. So this is Colles when there is dorsal angulation. This is when volar angulation, so it's Smiths. And when Colles or Smith involves the articular surface of the radius,
Barton's.
it is
Barton.
Barton's. This and this, unless there is a gross abnormality or distal neurovascular compromise, you don't need to admit them. Hematoma block, reduce, and fracture clinic follow. When will you admit this or this apart from gross neurovascular compromise?
In spite of reduction,
You reduced it, it's done, fantastic. You put a plaster. When will you admit? What is the population we see in
Elderly people who can't take care of themselves at home.
Absolutely. In the middle of the night, when there is no navigation team to arrange for this social care or plaster care, you will admit them, right? Under medical team. So think like that. This is lateral thinking. They might say, this is a 55-year-old, 85-year-old who's come with fallen outstretched hand. You've done the X-ray, given pain medication. What 2 points in history would you like to ask to this patient?
Who takes care of our home does she live?
Activities of daily living and previous falls. Then they will say, X-ray shows Colles fracture, you've done a hematoma block and reduced it. You put a plaster, what will be the appropriate disposition?
yes,
You'll say, oh, go home. But you forgot to read, it was 95-year-old and it was 3 o'clock in the night. So there is no navigation team to make a decision. They will not be able to take care of themselves at the age of 90, 95. Monteggia and Galeazzi. So points to remember is fallen outstretched hand or being direct blow. So Monteggia, Galeazzi, both need admission, both are unstable, open reduction, internal fixation. The thing they like to ask is, which is Monteggia, which is Galeazzi? Football fans? Football fan. Which team do you support?
FC Barcelona.
Okay. You? No. Which team is here?
Manchester United.
Manchester United, good. So Monteggia is ulnar fracture. The other one is the other one. Okay. So Monteggia is fracture of the ulna and anterior dislocation of radial head. So fracture of the ulna, anterior dislocation of radial head. Okay. Manchester United. Galeazzi is the other one. So there is a fracture of the radius and dislocation of distal ulna. Okay. Easy. Now we'll go to shoulder. What they have shown is some lesion over here, a chip fracture, which is called as Hill Sachs, a chip fracture, which is Bankart's. We have already studied this. How do you remember? Hill is on the top and the river bank is at the bottom. So that's your avulsion of the glenoid labrum and that's your avulsion fracture of the greater trochanter. Okay. Meissonier fracture. In Meissonier fracture, there is deltoid ligament which is gone, avulsion of the syndesmosis, and there is a spinal fracture of the proximal tibia. They won't ask Meissoniers for intermediate. They might ask tibial plateau fracture or bumper fracture. So whenever there is a tibial plateau fracture, think as a long bone fracture. It's a tibial plateau. They can't wait there or something, you need to give adequate pain medications and refer to the orthopedic team. Okay. The picture is very unclear. I'll give you the scenario. 59-year-old, twisted knee injury, fell down, since then unable to weight bear. On palpation, is tender on the lateral knee joint. Knee examination wise, passive movement not possible, active movement not possible, passive possible with pain. The valgus test is normal, varus test is painful. You suspect lateral collateral ligament injury. You've done an X-ray and you see closely a tiny chip fracture over here. It's a very tiny chip fracture. You guys can Google it. It's called a Segund fracture. The reason it is important is Segund fracture will have 100% of the time anticruciate ligament injury. 75% of the time medial meniscal injury. And lateral capsular ligament 75% of the time. Similarly, if there is a chip fracture here, it's called as reverse Segund. The only difference is it will have 100% of the time posterior cruciate ligament gone and medial meniscus and MCL. Let's see fractures of the spine. Name them, just name them. C1. Jefferson. C2.
Hangman.
Okay. Vertebral body. Chance. Chance fracture. Okay. Transverse process of C7. So that's your C2. That's your C2. That's your C1 fracture. This is the atlas. That's your chance fracture. Vertebral body is gone. And this is Clay-Shaveler. Okay, Clay-Shaveler fracture. Foot injuries. Ottawa foot rule, Ottawa knee rule, you guys should know. Ottawa ankle rule. Okay, I'm not going to discuss that at all. This one is critical because the tendon of flexor peroneus brevis goes and attaches over here. So when it avulses, there is a chip fracture over here called as pseudojones. And when the syndesmosis, at the level of syndesmosis there is a fracture, it's called as a Jones fracture. And anything beyond the syndesmosis is the stress fracture or shaft fracture. Okay. The reason is because the management. For pseudojones you can allow weight bearing. For these two you don't want them to weight bear. You can put shoe, you have to put posterior leg cast. Within 1 week orthopedic follow this walking boot for 1 to 2 weeks and then follow, that's fine. But main thing is weight bearing, no weight bearing, no weight bearing. Boot, plaster. Okay. Which tendon is inserted? Just making sure that you guys are keeping your ears open.
You said peroneus brevis.
Yes. Peroneus brevis. Good. Okay. So, this scenario is 25-year-old, tall female, wearing heels, walking down the stairs, has twisted ankle or foot injury. In primary exam, there was a question. Ankle joint is stable in which position?
Stable on the
So ankle joint is stable.
What is this?
What? Dorsiflexion. This is dorsiflexion.
Dorsiflexion.
Yeah, ankle joint is stable in dorsiflexion. Now this lady is wearing heels.
It will be plantar fracture.
It's unstable.
Unstable.
Now she twists it and then she is not able to weight bear. You do an AP lateral view of the foot and this line doesn't come straight line. There is a big gap over there. And that's your Lisfranc injury. If it is too much displaced, then it will need surgical intervention. Describe the abnormality on this X-ray.
There's a buccal fracture.
A cortical defect is seen at the distal radius, buccal fracture
Sorry.
or green stick fracture. Yeah. If it was both the sides, it's not a green stick, it's just a buccal fracture. What's the other name? Torus fracture.
Torus fracture.
Yeah. How do you manage this?
Then advice.
Hmm?
Defect advice. They need not come to the fracture clinic.
So you put a splint, no plaster, pain management. You may or may not refer to fracture clinic based on your current hospital policy. For exam purposes, fracture clinic follow. 14-year-old was playing in the school and she fell. She comes with painful knee and she is not able to do active movement, but passive movement is possible with discomfort. What is the abnormality you will see on this X-ray?
Tibial.
Okay. Proximal tibial avulsion fracture. Yeah. What is the pathophysiologic cause of this?
Extensive use of the.
What is the pathophysiological basis? What is the other name, if I ask? What is the other name? It is osteochondritis. Yeah. Osteochondritis of the proximal tibia, and it's called as Musculoskeletal, rest, ice, compression, elevation, reassurance, pain management. What is the similar pathophysiological condition in the navicular chorus? In the navicular.
Is it? What's the name?
It's called as colus.
Colus.
If it's in the calcaneum, it's called as sivers. Okay. It's given in your books. Crito.
Ossification center of the.
So ossification centers appearing in sequence. C is capitulum, radial head, inner epicondyle, lateral trochlear, olecranon, and lateral epicondyle. 1, 3, 5, 7, 9, 11. In this order it will. So the previous one should be present. If the previous one is not present, the only reason is we need to know that okay, this is a 3-year-old. So in a 3-year-old, this should be present, and this should be present. This may or may not be present. However, this should not be there. That means this is a fracture. Or this should not be there. This is a fracture. The reason is to identify the sequence. So if there is a 9-year-old, all this is okay, but there should not be a chip over here. However, if this is present, there can be a chip here because that's the next one to come. So maybe in this guy, it came at 9. But if this was absent in an 8-year-old, 9-year-old, that means this should not be present. You got the idea?
Yeah, I got that. So the age, sir, repeat the age, please.
1,
1,
3,
3,
5, 7, 9, 11.
1, 3, 5, 7.
Supracondylar fracture. Okay? Patient is come with fall on the elbow or fall on outstretched hand and not moving the elbow. You thought it was a supracondylar fracture, but the X-ray looks normal. However, in this X-ray there is a radial head fracture over here. How would you identify indirectly? What two lines would you draw?
Posterior pad.
Sale sign.
So you will look for fat pad, anterior or posterior, and you will draw anterior humeral line, which will be like this. It should go through middle of it or outer 1/3, and radiocapitular line. Anterior fat pad can be normal. You have seen obese people, right? Yeah, they have fat pad over here, and now we have accepted that that's normal, right? Imagine somebody is having a fat pad over here. That's not normal, that's Cushing's. So anterior fat pad can be normal unless it looks like a sail of a boat. Unless it looks like a sail of a boat. However, posterior fat pad is also present over here, and that's not normal. So there is some supracondylar fracture. You need to read about the indications for admission in supracondylar fracture. So here you can't write hemodynamically unknown or signs of red flags. Here you need to give, I think it's like 20% lateral displacement. You can write distal neurovascular compromise for any fracture. Admission, reason for admission, distal neurovascular compromise. But then there are specific reasons for admission. Okay, this is the scaphoid fracture. Which part undergoes necrosis?
The proximal one.
The proximal gets necrosed because the blood supply is this way. Okay? This is a big confusion to everybody. What is lunate, what is perilunate, you remember, then you forget the next day. And with all respect, the person who's named this was himself confused. He should have named it lunate dislocation or capitate dislocation. Not lunate, perilunate. Because if you draw a simple diagram of a distal radius, on the top of the radius is your moon. Moon is called as lun. So lunate. On the top of the lunate is the capitate. Now, lunate dislocation. Capitate dislocation. For exam purposes, perilunate dislocation. Easy?
Very easy.
Yeah. So don't try to memorize. This is present here. That means it is perilunate. This is gone. Lunate. Okay. So which one is this?
Perilunate. No. Lunate.
So it's lunate dislocation. Which one is this?
It's present there.
So it is like this. The moon is present on the top of radius. The other one is gone.
Perilunate.
It's perilunate.
Capitate.
Perilunate.
What is this?
It's present there, it's perilunate.
No, I see the capitate is here. The lunate is here.
It's normal.
Is it normal?
There's a chip there in the.
I mean, there's a small fracture there.
There is a chip fracture
There's a
over here.
fracture there, but there's no dislocation.
No dislocation, but there is a chip fracture here. So what is this called? Which bone is in fracture? That is your triquetral fracture. So whenever you see any chip on the back of the wrist, It's tricutal fracture.
Tricutal.
Okay. This needs to be plastered and sent to fracture clinic. Who is this?
Who's this? Who's this?
Yeah.
What is
Or what is it?
the gap between the teeth?
Oh yeah, the gap between the teeth. It is Mr. Terry Thomas. Terry Thomas sign. Scapholunate dissociation. This is your lunate bone. This is scaphoid. When the gap increases, it is called as scapholunate dissociation, and the sign is called as Terry Thomas sign.
Oh, after that person.
After that person who lost his teeth. We will pause over here. We'll continue with lower limb.